Thank you for being here with us. I hope this presentation can be very useful for you and for your patients. My name is Sergio Tamayo. I am a gynecologist and I work in reproductive medicine at INSER Medellin. I decided to call this lecture The Art of Frozen Embryo Transfer Back to Nature, because it cannot be something like a kitchen recipe. It's something you have to understand and at the end, do it the best you can. First, or years ago, the major focus of fertility research was on improving embryo quality and identifying a healthy embryo. However, even with the latest technology for genetic studies, like fish and other kind of techniques, the ongoing pregnancy rate with normal all euploid embryos was something around between 50 to 60%. So that means that other factors different than I'm sorry, than chromosomal abnormalities are responsible for 40 to 50% of failure treatments. So more recently, attention has been directed to endometrium to attempt to optimize the chances of embryo implantation. The first successful IVF treatment was achieved in a fresh embryo transfer with no ovarian stimulation. So after starting using gonadotropins in the 80s, having more eggs and having more embryos, increasing the pregnancy rate per cycle, but with the inconvenience of having a large number of supernumerary embryos, which were not chosen for the first transfer, that was a problem. So embryo cryopreservation, in that moment still with slow freezing, was introduced and seen as an answer to excess embryo production and also a strategy to avoid multiple pregnancies. Freezing after that was extended also to oocytes, and nowadays slow cryopreservation techniques has largely been replaced by vitrification. So the reason is because we are using this technique more and more every day is because survival of oocytes, cleavage, and blastocyst stage embryos has improved a lot. So having very good results in terms of pregnancy rates, improvements in the lab conditions, also the limitation on the number of embryos to be transferred, leading to single embryo transfer nowadays. This is gonna result in a lot of surplus embryos that usually vitrified prevent embryo wasting of this one that were not chosen to do the transfer. At the end, increasing the pregnancy rates because the patients, if they don't get pregnant, they can try in the next cycle without doing a new ovarian stimulation. These are some reasons why delayed transfer with oocytes or embryo cryopreservation is useful, like in the scenario with high risk of ovarian hyperstimulation syndrome, if the Center of Fertility has the policy of freeze all embryos and then do the embryo transfer. Also in couples desire to do pre-implantation genetic screening, PGTA, or in the scenario of premature progesterone rise. And also in treatments like surrogacy, or if the patient has previously done fertility preservation treatments. So there are many ways to prepare the endometrium for frozen embryo transfer. The following options to prepare the endometrium for frozen embryo transfer are available. So hormone replacement therapy with or without co-treatment with gonadotropin releasing hormone analog, a stimulated cycle with clomiphene, letrozole, gonadotropins, a pure natural cycle, or the last one that is the modified natural cycle. So having the patient in front, the first question will be if the patient has or not ovarian function. Also, if she still has ovarian function, it is regular or not. So it is obvious that when there is no ovarian function or is it not regular, it is not a good idea to let the ovary be in charge of the endometrium growth. When the patient has normal ovarian function, we have 4 options, or true natural cycle, modified natural cycle, simulated cycles, like in patients with irregular cycles or PCOS, or hormone replacement treatments with or without the previous agonist. So I'm going to focus on the first 2 options. I'm going to talk about the true natural cycle and modified natural cycle. This image reminds us what we must take into account when we want to carry out a natural cycle to prepare the endometrium for the embryo transfer. So as you can see in this picture, the pituitary gland releases FSH, which stimulates the growth of the dominant follicle in the ovary. And as it grows, the concentration of FSH is gonna decrease. But as it grows, it's also going to release estrogens. So these estrogens will be responsible for making the endometrium grow. In turn of these estrogens, this will cause the release of the LH that finally is going to generate the ovulation of the dominant follicle, and with this start the release of progesterone that is finally needed to make the desired changes in the endometrium to be receptive to the embryo. And this is very important, the so-called window of implantation. It's a concept that has been proposed to define the period of time of receptivity of the endometrium. Obviously for the embryo implantation during natural cycles or even in reproductive treatments. So the duration and molecular basis of this window of implantation remains unclear, although it is thought to last from 2 to 4 days in the mid-luteal phase. So this is the place, or better, the time that we are looking forward when we are preparing the endometrium for an embryo transfer. So the most important factor for a successful implantation are availability of a good quality euploid blastocyst and obviously a receptive endometrium. And of course, the synchrony of these two. So a recent development in assessment of the window of implantation is this ERA test, a multi-gene microarray that brings together gene studies with bioinformatics to associate with what endometrial is receptive or not. So it is studied like 238 genes, and the results came saying that the endometrium can be pre-receptive, receptive, or post-receptive. But this is a topic that it can take us a full lecture. So natural cycle is the preparation of endometrium during the natural cycle using the patient's own follicular sex steroids. There is no medical intervention except for endocrine measuring of the hormones, and obviously the ultrasound to monitor during the proliferative phase, the follicle, the dominant follicle, and the thickness of the endometrium. In this protocol, the timing for embryo transfer, it depends when the spontaneous LH surge happens, or when happens the administration of the HCG. So the last one, administrating the HCG, is the modified cycle. So after the HCG, ovulation occurs after approx like 36 to 38 hours. And the success of the natural cycle depends on the accurate, knowing when the ovulation happens. We have to be very precise about this. Because we have to know when the ovulation is going to happen, we have two options. The first one is to measure the LH in blood, but it's not a good idea for the patients. And the other option is to measure the LH surge in urine. So for that, we have to do it like 2 times per day. And that way we're gonna be sure when it's getting higher. We have to keep in mind that the LH levels in urine increase like 21 hours after the detection of the LH in blood. So it is the fact that it has to be taken into account. We have to have the consideration when interpreting the increase in LH in urine to know when it's going to happen, the ovulation. So during the estrogen phase, the endometrium demonstrate like a linear growth, as you see in the left picture, resulting in the typical appearance of the full thickness endometrium of 3 layers, like trilaminar. After ovulation, the endometrium keeps growing under the influence of progesterone, resulting in a homogeneous hyperechoic pattern on the ultrasound. So this increased endometrial density, as you can see in the right picture, is the moment that we want for the embryo transfer. And the importance of the growth of the endometrial thickness during the estrogen phase is very clear now, because different publications demonstrated that optimal clinical and ongoing pregnancy rates after IVF, the increase after a thickness of 8 millimeters in first cycle, or after 7 millimeters in transfer of frozen embryos. So in natural or modified natural cycles, the embryo transfer is performed 3 to 5 days after ovulation, depending on when the embryos were frozen. So if we are measuring urinary LH, will be LH plus 6 or HCG plus 7 if it's a blastocyst. If we want to measure in blood LH surge has been described as an increase of the level of LH beyond 180% of the level observed in the previous 24 hours. Others said that a surge of LH is when the LH is 10 or more, so it's up to you. So this is very important, because when an unexpected early ovulation occurs, the cycle is generally canceled. So this happens around 7 to 12% of the cases. So we have to be aware of that. This is crucial. The timing to perform the embryo transfer, I suggest, that it's a personal opinion, that I suggest that don't give HCG when the spontaneous LH surge is detected, and neither than additional luteal phase support. This can impact the natural course of the endometrium receptivity and can cause like a shift in the window or implantation. This is just an hypothesis, but it's a very common practice. So this is very much the same as the last slide, but to memorize this, this image can help us. So in a modified cycle with HCG trigger, obviously, we can do the transfer on day embryonic age +2. After the injection, for example, day 5 embryo at blastocyst, we're going to do the embryo transfer and on HCG +7. In a true natural cycle with spontaneous LH surge, on day of embryonic age +1, so after the LH surge, and a blastocyst embryo is going to be LH +6, as you see in the picture. So which method is the best one? Evidence shows us that there is no difference between the natural cycle and artificial cycle with regard to clinical pregnancy, ongoing pregnancy, or live birth. So because pregnancy rates do not differ between the natural and artificial cycles, therefore, lab conditions, social status, and physicians and patients' preference are effective for making a decision in choosing which one of the protocols to use. And last but not least, is it safe to do a frozen embryo transfer, or does it has like an adverse effect on pregnancy or fetal conditions? So several studies like this one evaluate and compare the obstetrics and prenatal outcomes of children conceived by both fresh and embryo transfer or frozen embryo transfer. This meta-analysis found that pregnancies achieved after frozen embryo transfer have a reduced risk of preterm birth, small for gestational age, and low birth weight babies, but higher risk of large for gestational age, as well as hypertensive disorders of pregnancies. If you compare with fresh embryo transfer, but that is not 100% true. Other studies says that it happens when there is no luteal carb. So maybe it's very similar at the end. So the take-home message is that there is no ideal method for endometrial preparation for frozen embryo transfer. So physicians and patients' preference are effective for making the decision in the choice between these options. Obviously, take into account that the natural cycle for embryo transfer demand more follow-up of the clinician, and not being able to program the embryo transfer at the moment you want is less flexible. Is when it has to be done. So thank you very much. If you have any questions, you can send me a text message by WhatsApp or Instagram.